What if your medical chart says you are completely perfectly healthy? Like your hormone levels are optimal, your blood work is flawless, but your body is telling you something is just horribly wrong.
Yeah, it is the absolute definition of diagnostic muddy waters.
Right. And today, we are looking at a medical paradox that leaves, honestly, millions of women feeling entirely dismissed by the medical establishment.
Absolutely dismissed. And if you were sitting there listening to this, and you or someone you know has been told by a doctor that, your labs look fine, while you are actively suffering from genitourinary syndrome of menopause, or GSM,
Yeah,
we really want you to know that the symptoms are real.
they are very real. And we are zeroing in on this highly specific, incredibly frustrating mystery. Why do some postmenopausal women experience persistent, debilitating vaginal dryness despite having optimal systemic serum estrogen levels from their HRT?
Because the science actually explains exactly why it's still happening.
And that is our mission today. We are synthesizing clinical guidelines from the British Menopause Society and the American Urological Association.
Right. Along with some really advanced cellular research on the extracellular matrix from Frontiers and clinical pathways from specialized women's health clinics.
Yeah, we're going to unpack the invisible cellular, structural, and, well, even lifestyle factors that create a localized desert in the body, even when your systemic circulation is getting exactly what it needs.
Because to understand that core paradox, why the systemic estrogen flowing in your bloodstream just isn't reaching the local vaginal tissue, we have to look at how that localized tissue actually maintains hydration.
Right. It's not just a static thing.
No, not at all. It's an incredibly dynamic, self-sustaining microenvironment. In a premenopausal or fully estrogenized state, local estrogen drives the superficial epithelial cells lining the vagina to constantly shed.
And when they shed, they release large amounts of glycogen, right?
Exactly. And that glycogen feeds the lactobacilli, which are the beneficial bacteria in the vaginal microbiome.
Which is so crucial.
Right, because when the lactobacilli metabolize that glycogen, they produce lactic acid. And this keeps the vaginal pH safely below 5.
Which is pretty acidic.
It is, but that highly acidic environment is exactly what keeps the tissue plump, moist, and hostile to pathogenic bacteria like E. coli.
But when systemic estrogen fails to reach this localized tissue in sufficient doses, that entire metabolic ecosystem just collapses.
It completely crashes. The epithelial cells stop shedding, the glycogen disappears, the lactobacilli basically starve, and the pH shoots up.
Leaving you with a tissue environment that is dry, irritated, and just highly vulnerable to infection.
Exactly.
Okay, let's unpack this. Is systemic HRT sort of like watering the roots of a giant tree, but the water pressure just isn't strong enough to reach the outermost leaves?
That's a great way to look at it.
Like the trunk is fine, the major branches are healthy, but those delicate outer leaves are still withering.
Yeah, if we connect this to the bigger picture, the human body is fundamentally a survival machine. It prioritizes systemic, life-sustaining organs, the brain, the heart, the vascular system.
It's triage, basically.
Exactly. The vascular distribution network heavily favors those vital systems. So, if the dose of systemic estrogen isn't perfectly calibrated to overcome that internal distribution hierarchy, the microcapillaries in the genitourinary tract are simply bypassed.
Wow, so the water pressure just drops before it reaches the leaves.
Right. Which explains why up to 25% of women taking systemic HRT still experience persistent urogenital symptoms. The distribution network is just failing the local tissue.
But our sources say it goes much deeper than just a lack of moisture on the surface. We need to zoom in with a microscope to see what is structurally breaking down inside the tissue itself.
Oh, definitely. We're talking about the extracellular matrix, the ECM.
Right, the ECM.
The ECM is the physical scaffolding that holds your cells together. And in a hypoestrogenic state, this matrix fundamentally mutates.
Mutates, that sounds intense.
It really is.
Right.
First, you have these structures called vaginal rugae. These are the deep corrugated folds in the vaginal wall that provide mechanical stretch, elasticity, and expansion. Without enough local estrogen to maintain the underlying cellular architecture, those folds literally atrophy and flatten out.
Here's where it gets really interesting, because you might hear vaginal dryness and instinctively think of like a dry sponge.
Right, exactly.
The assumption is that you just need to add water or a basic lubricant, and the tissue will just plump right back up to its normal state.
But it doesn't work that way.
No, the research from the Texas Medical Center shows that the actual physical material of the sponge is mutating into something entirely different. It's becoming stiffer, more fragile, and incapable of holding moisture even if you introduce it.
And this structural degradation is exactly why friction doesn't just cause mild discomfort. It causes micro tears, bleeding, and severe burning pain.
Because the tissue has literally lost its mechanical elasticity.
Right, and at the molecular level, there's this vital hydrating molecule called hyaluronan, or HA.
HA is incredible, right? It can hold up to 1,000 times its weight in water.
It is, and it's naturally abundant in a healthy ECM. But HA doesn't just float freely. It has to anchor to a specific signaling receptor on the cell surface called CD44.
So if the tissue is starved of local estrogen, what actually happens to those CD44 anchors?
They significantly decrease. The receptors basically vanish.
Oh, wow.
So even if the body produces hyaluronan, or if you apply a basic moisturizer, the HA molecules have absolutely nothing to bind to. The tissue has lost its biological ability to lock moisture in.
That is so frustrating.
It gets worse. Mechanically, the most destructive change is what we call the collagen flip.
The collagen flip. Yeah, this is where the cellular research gets a bit terrifying, frankly.
It does. Healthy vaginal tissue relies on a high turnover of type 3 collagen fibers.
And type 3 collagen is often found in embryonic tissue, right? It is highly flexible, elastic, and responsive.
Exactly. But when local estrogen drops, the synthesis of those small, flexible fibers plummets. They are entirely replaced by type I collagen fibers.
And type I is what makes up your tendons and bones. It is large, rigid, and stiff.
Right. And concurrently, the research highlights a massive spike, sometimes up to 65 times higher than normal, in a major cellular protein called periostin.
65 times, that's huge.
It is, and periostin actively cross-links with that new, rigid type I collagen. We normally see high levels of periostin in conditions like pulmonary fibrosis or cardiac scarring.
So it's basically creating scar tissue.
It essentially glues the stiff fibers together, yeah.
Yeah.
So tracing back to your sponge analogy, the soft, porous material of the sponge has been chemically replaced with a brittle, calcified wire mesh.
Wow. Okay, wait. If the local structure is failing because the systemic water pressure is too low to reach it, why can't we just give a patient a massive dose of systemic estrogen?
Just flood the system.
Yeah, turn the hose up all the way, overwhelm the systemic hierarchy, and just force that local tissue to heal.
Because the cells themselves might be actively changing their locks.
The lock.
Yeah, what's fascinating here is the concept of the receptor rebellion. Estrogen doesn't just wash over tissue and magically initiate healing. It functions as a highly specific key fitting into a lock.
And those locks are the estrogen receptors, primarily estrogen receptor alpha and estrogen receptor beta.
Exactly. In a healthy premenopausal state, alpha and beta exist in a delicate, finely tuned balance. Alpha promotes cell proliferation, while beta modulates and keeps alpha in check.
But in diseased or estrogen-deprived states, like the prolonged atrophy that leads to pelvic organ prolapse, that ratio goes completely haywire, doesn't it?
Totally haywire. Beta virtually disappears.
The clinical data shows that postmenopausal patients can exhibit an estrogen receptor alpha to beta ratio that is 2.7 times higher than healthy controls.
Yes, the ER alpha locks completely take over the tissue.
Yeah.
And if you are dealing with severe persistent symptoms, this matters to you because when the estrogen for your HRT enters this heavily altered lock, it opens a completely different metabolic door.
So it's like sending a rescue team to save a collapsing building, but because the radio frequency changed, they receive orders to demolish the building instead.
That is a perfect analogy. And because they receive those reversed orders, the rescue workers start actively tearing down the walls.
Oh.
In this case, the unchecked ER alpha triggers a massive cellular release of enzymes called matrix metalloproteinases, or MMPs.
And MMPs act like molecular scissors, right? They are literally designed to chew up, degrade, and dismantle the tissue matrix.
Exactly.
Well, at the same exact time, the cellular inhibitors that usually act as a protective sheath for those scissors, the tissue inhibitors of metalloproteinases, or TIMPs, are severely decreased.
Precisely. So you could have optimal estrogen levels perfectly circulating in your bloodstream. But if your local vaginal tissue has altered its receptor ratio, that estrogen is now signaling in the localized tissue to actively break itself down.
That is wild.
It is a highly localized biochemical dysfunction that a standard systemic blood panel is never, ever going to catch.
Okay, so we've established that the systemic distribution might fail to reach the microenvironment, and even if it does, the local receptors might be actively rebelling against it.
Right.
But what if we step outside of endocrinology altogether? Our sources from specialized women's health clinics suggest the culprit behind a localized desert might not be hormonal at all. What else actively hijacks this local microenvironment?
This is where differential diagnosis becomes absolutely critical, because there are systemic and autoimmune conditions that mimic hormonal atrophy flawlessly.
Lichen sclerosis?
Lichen sclerosis is a
Yeah.
prime example, yeah. It affects about 3% of postmenopausal women.
And it is an autoimmune condition where chronic lymphocyte infiltration attacks the basal layer of the skin.
Right, it causes the skin to thicken in some areas, thin out like parchment paper in others, and it creates just intense itching. Left untreated, it actually causes structural fusion of the anatomy
And yet, because it happens during menopause, it is constantly dismissed and misdiagnosed as simple estrogen deficiency.
all the time.
The sources also point to Sjogren's syndrome, another autoimmune disease where autoantibodies systematically attack the body's exocrine glands, physically destroying the biological mechanisms that produce tears, saliva, and vaginal lubrication.
But, it's not just complex autoimmune conditions. The clinical pathways emphasize the things sitting in your medicine cabinet right now.
Oh, the pharmacological aggravators, those are massive.
They really are. Take antihistamines. They're designed to block histamine, obviously, but they also have strong anticholinergic effects.
Meaning they block the neurotransmitter acetylcholine, which is what tells your secretory glands to produce moisture.
Exactly. So if you take a pill to dry up a runny nose, you are mechanically shutting down the secretory glands in every single mucous membrane in your body.
Every single one. And antidepressants, particularly SSRIs, have similar mechanisms, right? They blunt autonomic nerve responses and inhibit transudation, which is the process where moisture filters through the vaginal walls.
Right.
And we can't ignore the structural impact of the musculoskeletal system. The clinics highlight severe pelvic floor hypertonicity, which is when the muscles in the pelvic bowl are chronically tight or in spasm.
Think about what that actually means mechanically. Hypertonic pelvic floor muscles act like a tourniquet.
Like a literal clamp.
Yeah, they constrict the branches of the internal iliac artery, dramatically clamping down on the microvascular blood flow to the vaginal tissue.
Oh.
They also compress the pudendal nerve, blocking the autonomic nerve signals required to trigger natural transudation. You can have all the estrogen in the world, but if the vascular and neural highways are physically clamped shut by muscle spasms, the tissue will remain severely dehydrated.
So what does this all mean? It means a woman could have perfectly balanced hormones, she could be on the exact right dose of HRT, but her daily allergy pill or an undiagnosed autoimmune condition or chronic muscle tension is actively sabotaging her intimate health.
Absolutely.
But the clinic sources even mention seemingly harmless environmental factors that I would never have considered, like fabric softeners.
Yeah, the environmental triggers shock a lot of patients. Trace chemical residues left on your underwear from specific synthetic fabric softeners can cause severe contact dermatitis.
So the immune system reacts to the chemical, triggering localized inflammation that perfectly mimics hormonal burning.
Right. Hard water environments can also fundamentally alter the skin's barrier function, exacerbating vulvar irritation.
Even topical, over-the-counter anti-itch creams that contain benzocaine. The sources highlight this vicious cycle called the benzocaine rebound.
Oh, the benzocaine rebound is brutal.
You buy a cream to stop the itching, but the benzocaine disrupts the lipid bilayer of the cell membranes.
Right, leading to reactive hyperuricemia, which is a rush of inflammation that causes rebound mucosal dryness, ultimately making the itching substantially worse.
That is awful.
The clinical pathways even flag chronic sleep apnea.
Wait, really? Sleep apnea?
Yeah, if you are mouth breathing all night because your airway is obstructed, the chronic intermittent hypoxia triggers your sympathetic nervous system, your fight or flight response.
Oh, I see.
That sympathetic overdrive alters your systemic osmotic gradients, drawing fluid away from non-essential mucosal linings just to protect your vital organs.
So if you are experiencing persistent GSM, you really have to demand a holistic view from your provider. You cannot just throw more systemic estrogen at a fabric softener allergy or an autoimmune disease or a hypoxic breathing issue.
No, it requires a clinician willing to be a detective, really.
Yeah.
To look at the entire mechanical, chemical, and biological ecosystem rather than just glancing at a serum estrogen lab result and telling you everything is fine.
Which brings us to bridging the gap. Now that we understand the sheer complexity of this disconnect, the failing distribution network, the collagen flip to rigid wire, the rebel receptors sending demolition orders, and the massive list of autoimmune and lifestyle imposters, how is the medical community actually solving this?
Is a big question.
What is the clinical gold standard for fixing a collapsed microenvironment?
Well, the gold standard for genitourinary syndrome of menopause is combining systemic HRT with localized targeted treatments.
Oh.
If the vascular distribution isn't reaching the distal tissue, you just have to bypass the systemic route and treat the tissue directly.
Huh.
Local vaginal estrogen, which is formulated in low-dose creams, tiny dissolvable tablets, or celastic rings, is 80 to 90% effective at eliminating these specific symptoms.
Compare that to only a 75% effectiveness rate for systemic HRT alone.
Exactly.
And the brilliance of local estrogen, according to the British Menopause Society guidelines, is the delivery mechanism. Because it is applied directly to the mucosal surface, it saturates the local tissue receptors but undergoes massive first-pass metabolism before it can significantly enter the systemic venous return.
Right. The dose is incredibly low, so it doesn't spike your systemic blood levels.
It stays right where it's needed.
It does. It mechanically restores the acidic pH by bringing back the superficial cells, feeding the lactobacilli, and thickening that fragile epithelium.
Which is amazing.
But this raises an important question, right? If it is up to 90% effective, and clinical guidelines confirm it is incredibly safe even for long-term use, why do so few women actually receive this treatment?
Yeah. The British Society of Sexual Medicine guidelines call it a silent epidemic. Up to 84% of postmenopausal women have these localized symptoms, but only a tiny fraction get treatment.
Because there is a profound breakdown in communication. Patients assume the burning, pain, and dryness are just an inevitable, normal part of aging that they basically have to endure.
And doctors routinely fail to ask proactive questions about genitourinary health during checkups.
Exactly. But even for patients who cannot or prefer not to use localized hormones, we have incredibly sophisticated non-hormonal routes now.
Like high-quality hyaluronic acid moisturizer.
Right. Specialized HA moisturizers are highly effective at utilizing osmotic gradients to bind water back into the extracellular matrix.
Essentially acting as an artificial replacement for what the lost CD44 receptors can no longer hold.
Precisely.
There are also vaginal DHEA inserts, which leverage endocrinology. The tissue absorbs the DHEA as a prohormone and converts it locally into active androgens and estrogens, but only within those specific cells.
And for oral medications, there is ospemifene, which is a SERM, a selective estrogen receptor modulator.
So it's a pill designed to act as an estrogen agonist specifically in the targeted vaginal tissues, activating the healing pathways while acting as an antagonist in other areas like the breast tissue.
The absolute takeaway here is that you have a comprehensive arsenal of options to restore that localized cellular architecture. It does not have to be an either choice between systemic HRT and local therapy. Clinically, they work synergistically to protect both your systemic health and your local microenvironment.
Let's bring this all together. If you are listening to this and you are experiencing persistent GSM symptoms, the dryness, the burning, the recurrent UTIs, the painful intercourse despite being on systemic HRT, it is absolutely not in your head.
Not at all.
Your lab work might look picture perfect, but your localized microenvironment is in an active crisis. This is a highly complex biochemical and structural issue.
Yes.
You might be dealing with localized receptor imbalances, where your cells are actively degrading their own matrix. You might be dealing with a collagen flip, where your flexible, elastic tissue is chemically turning rigid.
Or, you might be dealing with an autoimmune condition, a medication side effect, or a hypertonic pelvic floor that is just hiding in plain sight.
You have every right to seek out localized, targeted therapies to fix that specific microenvironment.
And as we look to the future of women's health, there is a really provocative thought that builds on the molecular biology we've discussed today.
Oh, what's that?
Well, we know that the loss of local estrogen stops the production of glycogen, which starves the protective lactobacilli, raises the vaginal pH, and allows pathogenic bacteria to take over the tissue.
Right.
But as microbiome science and genetic bioengineering rapidly advance, we have to wonder, could we one day see treatments that directly manipulate the vaginal microbiome with genetically engineered probiotics?
Oh, wow. You mean completely skipping the hormone or receptor step entirely?
Exactly. Could we eventually bypass the need for local hormone therapy or SERMs altogether, simply by tricking the local bacteria?
That is fascinating.
Imagine a probiotic insert containing lactobacilli that have been genetically engineered to continuously produce lactic acid, hyaluronic acid, and hydrating compounds on their own, completely independent of human glycogen.
So they could artificially maintain a hydrated, youthful, low pH environment regardless of what the estrogen receptors or the extracellular matrix are doing.
That's the idea, yeah.
That is incredible to think about. Engineering the soil to manufacture its own water so the ecosystem thrives even if the internal distribution network fails
It
completely.
would change everything.
Until that day comes, remember, you do not have to endure the pain of a collapsed microenvironment. The targeted tools to rehydrate, rebuild, and restore that localized tissue exist right now. You just have to know to ask for them.